Perioperative nursing care includes care that is provided before, during, and after surgery. Surgery can take place in a variety of settings, including hospitals, freestanding surgical centers attached to hospitals, and the healthcare provider's office. You have to be able to perform strict surgical asepsis, appropriately document the care, and emphasize patient safety in all phases of surgical care. Effective teaching and discharge planning will prevent or minimize complications and ensure quality outcomes. A little bit of history in surgical nursing. During the 1970s is when ambulatory surgery centers, these outpatient surgery, short stay surgery, or same day surgery facilities began to be established. In 1982, Medicare began to pay for surgery performed in these centers, so they became even more popular. Usually patients are discharged after surgery in these facilities. However, some are held up for 24 hours to ensure the reversal of anesthesia or other surgery-related events. Benefits of the ambulatory surgery include anesthesia drugs that metabolize rapidly and have few effects that allow for shorter operative times. Their cost saving is achieved by eliminating the need for hospital stays. There is also a reduction in hospital-acquired infection because the clients are not staying in the hospital as long. Laparoscopic surgery is a type of surgery that involves the use of minimally invasive techniques that require small incisions with cameras or scopes for the performance of the surgery, as opposed to the large incisions that are required for an open surgery. The types of surgical procedures are classified according to the seriousness, urgency, and purpose of the surgery. Table 51 holds the classification for surgical procedures. Professional standards have been developed by the Agency for Healthcare Research and Quality, the American Society of Peri-Anesthesia Nurses, and the American Society of Anesthesiologists. These organizations provide valuable guidelines for perioperative management and the evaluation of process and outcomes. And as with everything in nursing, we look at the nursing process. It provides a clinical decision-making approach for the nurse to develop and implement those individualized plans of care for surgical patients. The aim of preoperative assessment is to identify the client's normal preoperative function, to recognize, prevent, and minimize possible postoperative complications. You conduct an initial interview to begin collecting that patient history, including past illnesses, surgeries, and reasons for the surgery. Table 50-3 has a list of medical conditions that actually increase the risk of surgery. Some of them include bleeding disorders, diabetes, cardiac disease, respiratory disease, liver disease, the use of street drugs, and immunological disorders. The way a client thinks about surgery and his or her physical and psychological states is going to affect how the client is going to respond to the surgical procedure. You need to find out, as the nurse, if the client has had previous surgery. How did they respond during the surgery? Was their pain controlled? Did they have nausea or any postoperative complications? The nurse also needs to ask about the use of antibiotics, antidysphymics, anticoagulations, anticonvulsants, antihypertensive, corticosteroids, and insulin, as these medications have special implications for a surgical client. You also need to remember postoperatively and at discharge to use the medication reconciliation process to make sure that the client continues their medication regimen. Clients don't always understand the concept of an allergy. An allergy is not the same as an unpleasant side effect. For example, after the use of codeine, if the client states it caused nausea, this is a side effect. However, if the use of codeine caused hypotension or a skin rash, this is an allergy. And again, clients don't always understand the difference. Table 50-5 will list drugs that have special implications for the surgical client. Chronic smokers will have an increased amount and thickness of mucus. Normally, general anesthesia will increase airway irritation and will stimulate additional pulmonary secretions. So clients and nurses have to work harder to maintain airway clearance. Clients that use alcohol or illegal drugs can experience adverse reactions to anesthesia because they have a cross tolerance to the anesthesia drugs, and they may need a higher than normal amount of anesthesia and pain medication. You need to remember that clients who use alcohol are often undernourished or malnourished, and they may be at risk for liver disease, portal hypertension, and esophageal varices, and can also experience withdrawal postoperatively. Support is going to be very important for the postoperative client. They need support with transportation, nutrition, laundry, and house cleaning, and in a variety of areas. So now we look at the risk factors for surgery. The very young and older adults are going to be at risk for complications because of immature or declining physiological status. Table 50-4 is going to have the physiological factors that place the older adult at risk during surgery. And while I'm on the topic of tables, there's a variety of tables in your books that can really help clarify or help you understand a concept, and I highly recommend that you take time to look at those tables and figures. Before surgery, you need to assess whether the client is on a special diet or if there's any factors that influence their food intake, such as their ability to chew and swallow. The presence of regurgitation after meals is another consideration. Obesity increases surgical risk by reducing ventilatory and cardiac function. Bariatric means obese. Embolus, atelectasis, and pneumonia are common postoperative complications in the obese client. Obstructive sleep apnea is a syndrome of periodic, partial, or complete obstruction of the upper airway during sleep. Clients that have conditions that alter their immune function are at a higher risk for developing infection after surgery. The severity of the stress response influences the degree of fluid and electrolyte imbalance. If the client has pre-existing diabetes mellitus or renal or gastrointestinal or cardiovascular abnormalities, the risk of fluid and electrolyte alterations is even higher. And in pregnant clients, the perioperative plan of care addresses not one, but two clients, the mother and the developing fetus. Preoperative signs are vital signs, including blood pressure while sitting and standing, and pulse oximetry, are going to help provide important baseline data that is used to compare alterations that occur during and after surgery. A lot of diagnostic screenings are necessary for surgical clients, and the table on 50-6 lists several of these screenings with normal values and interpretations. Additional diagnostic examinations can include ECGs, chest x-rays that have special emphasis on the elderly, or those that have chronic cardiac or respiratory illnesses. Clients can be typed and cross-matched for blood transfusions also, unless they've made a personal donation prior to the time of surgery. Excuse me, and usually that takes a couple-week process. Clients requiring emergent surgery often experience changes in their physiological status that require you to reprioritize quickly. But these are a list of some of the nursing diagnoses that surgical clients may need. It's the surgeon's responsibility to explain the procedure to the client and to obtain an informed consent. But if you as the nurse are witnessing a consent, it is important to make sure that the client has no additional questions. Preoperative teaching will cover a myriad of subjects and can be accomplished days or even a few weeks before the scheduled procedure. It should include postoperative expectations, including exercises that are designed to prevent complications such as turn coughing and deep breathing, and early mobility. It can include tours or directions to the hospital waiting room, the surgical suite, post-anesthesia care unit, or the PACU, which is another way of saying recovery room, or other hospital rooms. Anticipated postoperative IV lines, the PCA or the patient-controlled analgesia, potential NG tubes, pumps, drains, ventilators, etc. Encourage questions and answers from the patient and the family, and make sure that you educate them on pain and pain relief measures postoperatively. On the day of surgery, there are several routine procedures that have to be completed before releasing the client for surgery. If a preoperative assessment was done days or weeks prior to the surgery, you have to review that assessment to ascertain that it is still correct. To avoid injury, make sure the patient removes hairpins or clips prior to leaving for surgery. Hair pieces or wigs are also removed. The client will apply a disposable hat prior to entering the operating room to help prevent any loose hairs from getting in surgical wounds. They should not be wearing makeup or nail polish. This helps the surgical team view normal skin coloring and provide accurate assessments. The client needs to remove all prosthesis, including partials or complete dentures. Excuse me. A lot of times these can be removed once they get to the operating room. A lot of people are very self-conscious about removing their teeth in front of family members. The same way with artificial limbs, artificial eyes, or hearing aids. And usually it is very appropriate to provide like a denture cup to place these things in that has the patient's ID label on it. If a patient has valuables, give them to family members or secure them for safekeeping. Instruct the client to void before they leave for the operating room and prior to giving preoperative medications. An empty bladder is going to reduce discomfort during the procedure and will reduce the risk of incontinence during surgery. If you have not already done so, a final preoperative set of vital signs is necessary. Before they go to the operating room, make sure that the medical record is complete. They have the right labs, the consents are signed. A lot of facilities will utilize a preoperative checklist to make sure that all of these things have been taken care of. If an IV has not been started in or on the hospital unit, then it's usually placed in the preoperative holding area or maybe even the operating room. With the ambulatory surgery, there is a reduction of the use of preoperative medications, but the anesthesia provider or the surgeon sometimes will order pre-anesthetic drugs or on-call medications or pre-op medications to help reduce the client's anxiety, the amount of general anesthesia that's required, reduce the risk of nausea or vomiting and resulting aspiration, and respiratory tract secretions. The three principles of the Joint Commission protocol to avoid wrong site and wrong procedure surgery will include preoperative verification that ensures that all relevant documentations has been completed and placed on the chart prior to the procedure, and includes the type of surgery that's scheduled is consistent with what the client is expecting to be done. The second one is marking the operative site with indelible ink to mark left and right or multiple structures and levels of the spine. And then 3 is timeout just before the start of the procedure for final verification of correct patient, correct procedure, correct site, and any implants. An anesthesia provider will give general anesthetics by IV infusion and inhalation routes. General anesthesia can require endotracheal intubation during the procedure. Regional anesthesia can be administered as spinal, epidural, or peripheral nerve blocks. With regional anesthesia, there's no loss of consciousness, but the client frequently is sedated. Risks can occur with spinal anesthesia in that the anesthesia can rise upward in the spinal cord and can cause some breathing difficulties. Elevation of the upper body will help prevent respiratory paralysis. Local anesthesia will inhibit nerve conduction until the drug diffuses into the circulation. It's injected locally or can be applied topically. A client under conscious sedation has to independently maintain a patent airway and adequate ventilation and must be able to respond appropriately to verbal stimuli or light tactile stimulation. In other words, they're drowsy, but they can still be aroused easily. Once the client is done with the surgery, then they go to the recovery room or the PACU, which is the post-anesthesia care unit. A report is given from the OR staff to the PACU nurse. Assessments will be performed by the PACU nurse every 5 to 15 minutes or more frequently depending on the client's condition and unit policy. And this assessment will continue until the client is discharged from the PACU. They have different types of post-anesthesia recovery scores that are utilized to help determine if a client is actually ready to be discharged from the PACU. A score of 8 to 10 on the PARS or the post-anesthesia recovery score is usually an indication that the client's ready to be discharged. Evaluation of a patient's status and eventual readiness for discharge from the PACU is done on the basis of their vital sign stability compared with their preoperative vital signs. Inpatients will remain in the PACU until their condition stabilizes and then they return to the postoperative nursing unit. Ambulatory surgery recovery consists of a room that is equipped with medical recliner chairs, side tables, and footrests, or they may have the carts also. These clients are monitored the same as they are in PACU, but not at the same level of intensity. The Aldrete score has added 5 areas of functional assessment for the ambulatory surgery client that constitutes the post-anesthesia recovery score for ambulatory clients. Clients are discharged to home from ambulatory surgery when they meet certain criteria. When you're using the post-anesthesia recovery score for ambulatory clients, the client has to achieve a score of 18 or higher before they're discharged. You need to make sure that you review those written post-operative instructions and prescriptions with the client and family before releasing the client, and ensuring that they verbalize understanding of the instructions. And always discharge the client to a responsible adult. They've received anesthesia, and they should not be driving, and they should not be alone for a while. To assess a client's postoperative condition, you need to use critical thinking while relying on information from their preoperative nursing assessment and knowledge regarding the surgical procedure that was performed and events that might have occurred during the surgery. You need to be aware that certain anesthetic agents can cause respiratory depression, and one of the greatest concerns in the PACU is airway obstruction. The client is at risk for cardiovascular complications resulting from actual or potential blood loss from the surgical site, side effects of the anesthesia, electrolyte imbalances, and depression of the normal circulatory system regulating mechanisms, and ischemia. The OR and recovery room environments are usually very, very cool or even cold. And the client's anesthetically depressed level of body function results in the client being cold after surgery. They have a lowered metabolism and a fall in their body temperature. In rare instances, there is a genetic disorder known as malignant hyperthermia, which is a life-threatening complication of anesthesia. Despite the name, an elevated temperature is a late sign of malignant hyperthermia. Increased expired carbon dioxide is one of the first signs in this situation. Because of the surgical patient's risk for fluid and electrolyte abnormalities, make sure that you always assess the hydration status and monitor for signs of electrolyte alterations. As the anesthetic agents begin to metabolize, the patient's reflexes will return, muscle strength will be regained, and a normal level of orientation will return. Primary causes of postoperative complications will include impaired healing of the surgical wound, the effects of prolonged immobilization during surgery and convalescence, and the influence of the anesthesia and analgesics. Table 50-9 will have common postoperative complications for you. To prevent respiratory complications, you need to begin pulmonary interventions early. Some clients are going to be at greater risk for venous stasis due to immobility. Pain control is going to be a priority to facilitate a surgical patient's recovery. Clients are often cool after surgery, and that PACU nurse provides warmed blankets as soon as possible. If the client's temperature is 96 degrees Fahrenheit or below, a forced air or connective warming device is frequently used. And reorient the client in the PACU, explaining that surgery is completed, describe the procedures and nursing measures that are being done. An important nursing responsibility is maintaining the patency of IV infusions in the PACU area in the postoperative period, because this is the client's only source of fluid intake immediately after surgery. Normally, a client who has had general anesthesia does not receive fluids to drink in the IC or in the recovery room because they have bowel sluggishness, the risk of nausea and vomiting, and grogginess from general anesthesia. But when they do start receiving fluids, we start slowly. And they get ice chips, clear fluids, then full liquids, etc., or per the physician order. The depressant effects of anesthetics and analgesics will impair the sensation of bladder fullness. If bladder tone is reduced, the client has difficulty starting urination. So we also need to be aware of how long it has been since the client has urinated. If they go past 8 hours or they begin getting very uncomfortable before they or since they have urinated, then we may need to do a straight cath. During recovery and the acute postoperative care, make sure that you assess the condition of the client's skin, noting pressure areas, looking for rashes, petechiae, abrasions, or burns. Excuse me. After surgery, a lot of surgical wounds will have dressings that protect the wound site and collect drainage. And you need to keep an eye on these dressings, watching the amount, color, odor, and consistency of any drainage. The risk of developing a surgical site infection is determined by the number and types of microorganisms that contaminate a wound, the susceptibility of a host, and the condition of the surgical wound itself. So we need to assess these carefully. New dressings. Some surgeons on surgical patients do not want the dressings removed for 1 day or 2 days. I know some surgeons that don't want their dressings removed for 5 days. So you assess the dressing without removing the dressing itself. And usually if the dressing is saturated, you just reinforce the dressing. If a client has glucose problems, make sure that you're monitoring those levels routinely. Depending on the surgery, some clients do not regain voluntary control over their urinary function again, so make sure that you're keeping track of that. Inspect the abdomen for distension that can be caused by accumulation of gas. If they have a laparoscopic procedure, the abdomen is inflated with gas during the procedure, and not all of that gas is removed prior to closing the client back up, and this gas can be very uncomfortable. In a client that has had abdominal surgery, distension can develop if internal bleeding occurs. However, the abdominal distension is a late sign of bleeding. It can also occur in the client that develops a paralytic ileus or a non-mechanical obstruction that's caused by the lack of intestinal peristalsis because the bowel has been handled during the surgery. As clients awaken from general anesthesia, the sensation of pain becomes more prominent, and they will perceive pain prior to being completely conscious. Ongoing assessment of the client's discomfort and evaluation of pain relief therapies are essential during the postoperative course. The surgical client is vulnerable to fluid and electrolyte imbalances as the result of the stress of surgery, inadequate preoperative intake, and the potential for excessive fluid losses during surgery. You will also notice in some instances that they have given massive amounts of intravenous fluids during surgery, and so you can see edema in a lot of clients that was not there preoperatively. A lot of facial edema, scleral edema, just a variety of areas, but be aware that they can gain a lot of weight through third spacing because of a significant amount of intravenous infusion during the operation. Manipulation of portions of the GI tract during surgery can result in absence of peristalsis for 24 hours or sometimes longer. So you need to really be assessing bowel sounds. Rest is going to be essential for normal healing. As always, discharge planning will begin on admission or during the preoperative teaching phase. In the postoperative period, the nurse, the patient, and the family are going to work to prepare the client for discharge. The greater the amount of perceived information received about incision care, the higher the patient's knowledge rating. If a patient fails to progress as expected, make sure that you revise his or her care plan based on the evaluation findings and the client's needs.